Good morning, friends, and I thank Dr. Ashok Shroff for asking me to be here this morning. Friends, in last about couple of decades, the cataract surgery has evolved considerably. We used to do all intracapsular, then extracapsular lens implantations with sutures, and then phacoemulsification, and do different types of lenses available, etc. So the evolution of cataract surgery is one of the fastest in last 2 decades or so. But at the same time, today the patients also are extremely demanding. There are very high expectations from the patients, from the ophthalmic surgeons. There is very easy access of information from internet, etc. So the patients have very high knowledge of various pros and cons of various options for whatever treatment they are undergoing. So in short, spectacle independence has become a new evolved expectation in general, whether it is in younger age through LASIK or in older age after cataract surgery. And when we talk about spectacle independence after cataract surgery, what are the various options which we see? And obviously the first option comes to our mind is a multifocal lens. But these multifocal lenses have, like anything else, some advantages and disadvantages. In multifocal lenses, in general, there is some loss of quality of vision in the form of glare and halos, etc. All the patients may not be ideal candidate for multifocal lenses, and of course, the cost of the lens in our country is one of the main factors where it may not be available to every single patient. The second important thing which comes in our mind is active implants, which have come in last about 4 or 5 years. Few issues with accommodative lenses, that they are less effective for near. The distance vision becomes more, but the near N6 is very difficult. They can read reasonably well up to N10, I believe. But this advantage also gets lost over a period of time, and what is called as regression. There is a lot of learning curve to put these accommodative lenses for all of us, even if we are doing a very nice, wonderful cataract surgery. And once again, the cost of these accommodative lenses becomes a prohibitive factor to be put in a lot of patients or in many patients. So let us talk about monovision by monofocal lenses. Monovision, we have talked, a lot of things have been talked by previous speakers, but it is not a new method. It was popularized more than 50 years back for presbyopic contact lens wearers, and where one lens would correct the distance and the other for near. Conventional monovision and cross monovision, conventional usually dominant eye for distance and non-dominant eye for near. And how do we check dominance eye? There are various methods Dr. Himanshu has said, and the commonest method is the pinhole method, or if you do commonly like this and close one of the eyes, and you can do yourself, and you can find out whether right or left is dominant, and the dominant eye is usually to be corrected for distance. In monovision, ideally the dioptric difference between the two eyes, I'm talking about post-cataract surgery, should be about 2 to 2.75 diopter, but that might become a little too much for some patients, and what we call as mini monovision, or what Dr. Rubal said, micro monovision, where the difference is kept between 1 to 1.5 diopter between the two eyes. And the sole objective is patients should be able to carry out most of the activities without glasses, and we must tell them that they might still require glasses, say for example driving or night driving, watching movies or TV for a long time, and reading extremely small prints. The advantages of this concept is the quality of vision is maintained, and unlike, say, for example, in multifocal lenses, there is no learning curve at all. All of us have been putting this monofocal lenses every day, so there is no additional learning curve, and there is no additional cost involved at all. There are all the types of monofocal lenses available, right from the highest to reasonably priced, and there is no additional cost to the patient at all. So we did a study with the purpose of to assess the visual performance and acceptability of pseudophakic monovision in our institution, and all patients undergoing cataract surgery and having understood the concept of monovision. This is something very important. They were included. Patients not understanding the concept were excluded, and any other ocular existing comorbidity, the patients were excluded. Again, as has been discussed number of times, the pre-operative patient counseling is very, very important. The type of work patient requires to do in day-to-day work, he or she, how much amount of driving, how much amount of reading, etc. We need to understand and then tell the patients, not only the patients, even the relative about the concept. Then, of course, routine cataract work is done. And what we did usually, whichever I had more cataract, we corrected more for distance, and the follow-up was on day 1, day 5, and at the end of 3 months. Post-op unaided visual acuity for distance and near were assessed on day 5 and 3 months. And also patient satisfaction with monovision and level of independence from glasses were evaluated using questionnaire at the end of 3 months. And this was totally at the end of 3 months. Now we were also surprised to see the results that 85% of patients had binocular vision, I'm talking about, of 6 and 6. And 98% had more than 6/9 and more than N8, or at least 6/9 and N8. And this was very, very encouraging results in selected patients. And from the happiness point of view, 87% of the patients were very satisfied with the results of accepted monovision because the counseling was done very properly. People who were not happy, they either did not understand the concept very well, or genuinely they were not happy. The drawback of this study was we did not, the preoperative ocular dominance was not checked, whichever eye was first. Usually we corrected for distance, and stereopsis was not tested because it was difficult in advanced cataract to check for stereopsis in many, many patients. So, friends, pseudophakic monovision is a very good concept to reduce the dependency on glasses for most activities of daily living in pre-selected, pre-counseled patients. I thank you very much for your attention.